We will now continue with rheumatoid arthritis. Rheumatoid arthritis is an autoimmune disorder, predominantly of the joints, but with many systemic manifestations of chronic inflammation. The cause is unknown, although there is an association with specific HLA subtypes. As with most autoimmune diseases, rheumatoid arthritis is more common in women. Chronic synovitis leads to overgrowth or pannus formation, which damages all the structures surrounding the joint, including the bones, ligaments, tendons, and cartilage. Now here's a tip for you. Morning stiffness, multiple, small, inflamed joints is the key to diagnosing rheumatoid arthritis. The key to getting questions right on the USMLE for rheumatic arthritis is knowing the presentation. Remember, there's bilateral symmetrical joint involvement. The proximal interphalangeal joints and the metacarpal phalangeal joints of the hands are usually affected, but the wrist, knees, and ankles can also be involved. There will be morning stiffness lasting at least 30 minutes, but often much longer. This area of time is a place where the USMLE can trick you up. Remember, at least 30 minutes. Rheumatic nodules can be present in up to 20% of patients over bony prominences. Some of them may present to you with ocular symptoms, such as episcleritis. Others will have lung nodules and effusions. Lastly, a vasculitis can occur, which can affect the skin, bowel, and peripheral nerves. Rheumatoid arthritis has cervical joint involvement, particularly at C1 and C2. This can lead to subluxation. A Baker cyst may rupture and mimic a DVT. They're very common in rheumatoid arthritis. Patients can also have pericarditis and pleural disease, and remember, as we discussed earlier, carpal tunnel syndrome is very common. A little tip, remember the distal interphalangeal joint is spared in rheumatoid arthritis. The distal is only involved in degenerative joint disease. Here's a patient with rheumatoid arthritis. Boutonniere and swan neck are classic deformities of the hands. Here's a patient who's developed severe ulnar deviation secondary to rheumatoid arthritis. How do you diagnose rheumatoid arthritis? Well, you could check a rheumatoid factor, but it's only going to be positive 70 to 80% of the time. You see, rheumatoid factor is rather nonspecific and is associated with many other autoimmune and chronic infectious diseases. The better test is the anticyclic citrullonated peptide, anti-CCP. It's actually greater than 80% sensitive and 95% specific. So if on a vignette they mention anti-CCP as being positive, click rheumatoid arthritis. Other diagnostic tests for rheumatoid arthritis include an elevated ESR or CRP. You're going to get an anemia that's normocytic. This is specifically anemia of chronic disease because rheumatoid arthritis is quite chronic. Arthrocentesis on initial presentation isn't a bad idea to exclude the crystal diseases we've spoke about so far, including gout and calcium pyrophosphate deposition disease. It can also help to exclude infection. But remember, the arthrocentesis isn't going to diagnose rheumatoid arthritis specifically. It's just going to help remove diagnoses from your list of differentials. Lastly, you might see a modest elevation in lymphocytes. Now here's a little tip. If you're presented with a patient with dry eyes and dry mouth, and they complain of even other dry mucous membranes, it's Sicca syndrome. Now, rheumatoid arthritis loves to hang out with other symptoms, problems, and conditions. Felty's syndrome is one such example. It's rheumatoid arthritis combined with splenomegaly and neutropenia. Another one is called Kaplan syndrome. This is rheumatoid arthritis with pneumoconioses and lung nodules. The most important issue you must commit to memory is in rheumatoid arthritis, we want to stop the progression of disease. Any patient with erosive disease or X-ray abnormalities needs a DMARD, or disease-modifying anti-rheumatic drug. At the bare minimum, you need methotrexate to slow progression. You can upscale if necessary. Also, remember, the most common cause of death in rheumatoid arthritis is actually coronary artery disease. Now, I just mentioned DMARDs, or disease-modifying anti-rheumatic drugs. How do you know when to use them? Well, if neither NSAIDs or steroids are working to stop rheumatoid arthritis from progressing, you're going to need one. Also, any patient with erosive rheumatoid arthritis needs a DMARD as part of their initial therapy, not a few years down the line. A patient with long-standing rheumatoid arthritis is to have coronary bypass surgery, which is the most important step prior to surgery. Of all these choices, the correct answer is A, cervical spine X-ray. Rheumatoid arthritis is associated with C1 and C2 subluxation. Cervical spine imaging to detect possible instability of the vertebra is essential prior to hyperextension of the neck that typically occurs with endotracheal intubation. Checking a rheumatoid factor will not at all impact coronary bypass surgery. Plus, the patient's already diagnosed, so why check it again? Giving an extra dose of methotrexate does not work acutely, and again, does not change outcomes for surgery. Checking an ESR doesn't really help, it's nonspecific. And giving a pneumococcal vaccination at this time, again, would not help, and it also has nothing to do with the surgery. Erosive disease means three things: joint space narrowing, physical deformity of the joints, and other X-ray abnormalities. Methotrexate is the best initial DMARD for rheumatoid arthritis. However, it has three particular adverse effects you need to know for the USMLE. The first is liver toxicity. The second is bone marrow suppression, and the last is pulmonary toxicity. Tumor necrosis factor inhibitors, such as infliximab, adalimumab, and etanercept, are the first-line DMARDs for those not responding to methotrexate or have become intolerant to methotrexate. They're often used initially in combination with methotrexate to prevent disease progression. However, they have lots of toxicity. The first is that there's a concern of reactivation of tuberculosis. Therefore, all patients who are going to receive a TNF inhibitor must be screened with a PPD. Second, TNF inhibitors make you very susceptible to other infections. Rituximab is an agent originally developed for non-Hodgkin's lymphoma, and it's effective in rheumatoid arthritis as a DMARD by removing CD20 positive lymphocytes from circulation. This leads to excellent long-term control of rheumatic arthritic symptoms. Rituximab is also used in combination with methotrexate in those not responding to anti-TNF medications. When it comes to rituximab, you must screen the patient for hepatitis B. There have been numerous case reports of patients receiving rituximab and subsequently reactivating their Hep B infection. Hydroxychloroquine is an agent that can be used as monotherapy as a DMARD in cases of mild disease when you want to avoid the toxicity of methotrexate. However, it's most often used in combination with methotrexate for more advanced cases. Hydroxychloroquine is toxic to the retina, so always remember to do a dilated eye exam. Symptom control in rheumatoid arthritis is very important. These patients are in a great deal of pain. NSAIDs are the best initial therapy for the pain caused by rheumatoid arthritis. They work immediately to improve inflammation, but do nothing to prevent the progression of disease. Steroids also work in a matter of hours to control the pain of rheumatoid arthritis, secondary to the inflammation that it causes. I've actually seen patients who've come in unable to walk because of the pain. Given steroids, they were able to get out of bed just a few hours later. Steroids are used in two particular purposes. First, when NSAIDs do not control symptoms immediately, and second, as a bridge when waiting for DMARDs to take effect. You must keep in mind that DMARDs take a lot longer. They have a slower onset of action than steroids do, so you can use them as a bridge. Use a combination of TNF inhibitors and methotrexate as a DMARD when simple lone therapy with methotrexate fails. But remember, the adverse effects are mandatory for you to know. Last tip, steroids do not prevent the progression of rheumatoid arthritis. Always keep this in mind. So let's go over those adverse effects that you need to know about rheumatoid arthritis medications. Anti-TNF inhibitors can cause reactivation of tuberculosis. Hydroxychloroquine can cause ocular defects, such as retinal toxicity. Sulfasalazine can cause a rash and hemolysis. Rituximab can lead to other types of infections. Gold salts have been associated with nephrotic syndrome, and methotrexate can lead to liver, lung, and bone marrow issues. Now we're going to talk about juvenile rheumatoid arthritis, also known as Still's disease. Juvenile rheumatoid arthritis is very difficult to define as there's no known etiology. This does not stop it, however, from appearing on virtually every USMLE exam as either the correct answer or one of the distractors. So how does somebody with juvenile rheumatoid arthritis present? Well, this is unquestionably the single most important and nearly the only fact you need to know about it. The most important feature is the presence of high, spiking fevers, greater than 104 degrees most often, in a young patient that has no clearly identified etiology and also presents to you with a rash. The features of the rash are that it only occurs with fever spikes, it's salmon in color, and occurs on the chest and abdomen. Some other things to go along with juvenile rheumatoid arthritis is splenomegaly, pericardial effusion, and some mild joint symptoms. When diagnosing JRA, there are no clear diagnostic tests. Anemia and leukocytosis is often present. The ANA will be normal, but the ferritin as an acute phase reactant will be markedly elevated. To treat these patients, well, half of them improve with simple aspirin or NSAID therapy. However, if there's no response, use steroids. We're now going to discuss lupus. Systemic lupus erythematosus, or SLE, is an autoimmune disorder with a number of autoantibodies, such as an ANA or double-stranded DNA. It causes inflammation diffusely throughout the body. It has numerous abnormal blood tests associated with it, such as antiphospholipid antibodies. But this is not the same thing as knowing what causes SLE. Unfortunately, the etiology of SLE is still a mystery. The diagnosis of SLE is based on 4 of 11 known manifestations of the disease. There are 4 skin-centered manifestations. The first is a malar rash. The second is a discoid rash. The third is photosensitivity. And the last one is oral ulcers. Alopecia is common in SLE, but it's not officially a diagnostic criteria. Here's an example of a malar rash in someone with lupus. Patients with lupus will often complain of arthritis. It's actually present in 90% of those with SLE, and it's often the first symptom that brings patients to seek medical attention. SLE gives joint pain without deformation or erosion. That's why the X-ray is normal. Patients can have inflammation of the pleura and pericardium, known as serositis. This can give severe chest pain and at times can give both a pericardial or pleural effusion. Patients with lupus can also have renal manifestations. They can range from mild proteinuria to end-stage renal disease and requiring dialysis. The most common glomerulonephritis is membranous glomerulonephropathy. This is one where you have red cell casts and hematuria occurring. There are also neurologic manifestations, which include psychoses, seizure, or stroke from vasculitis. Many patients will have pneumonia, alveolar hemorrhage, and restrictive lung disease in SLE. But again, these are not criteria for diagnosis of the disease, just like alopecia is not criteria. Ocular findings also aren't part of the formal diagnostic criteria. So if you see photophobia, or retinal lesions, or blindness, these are just associated with lupus, but they're not official diagnostic criteria. Hematologic criteria include a hemolytic anemia, but the anemia of chronic disease is more commonly found. Lymphopenia, leukopenia, and thrombocytopenia are also seen. There are also immunologic or laboratory serologic abnormalities that fit diagnostic criteria. These include a positive ANA, or a positive anti-double-stranded DNA, anti-Smith, a false positive test for syphilis such as an RPR, and a positive LE cell preparation. Some additional findings you must keep in mind are mesenteric vasculitis, Raynaud's phenomenon, and antiphospholipid syndromes. A positive ANA is found in 90 to 95% of cases of SLE. A negative ANA, however, is extremely sensitive for lupus, but a positive ANA is poorly specific. Many rheumatologic diseases are associated with a positive ANA. Therefore, if it's positive, you're not necessarily sure if it's lupus, but if it's negative, you might be able to rule it out. Anti-double-stranded DNA is positive 60% of the time, and anti-Smith is positive 30% of the time. These are 2 antibodies that are only found in SLE and are extremely specific for the disease. Patients with lupus will have a decreased complement level. It actually correlates with disease activity. As disease activity increases, complement level will decrease. Anti-SSA and anti-SSB are found in only 10 to 20% of cases. They add little to the diagnosis and they're specific for Sjogren's syndrome. In fact, they're positive in 65% of patients with Sjogren's. One little tip for you. Whenever you're presented with a patient who's asymptomatic and has a positive ANA, do nothing. A 34-year-old with a history of SLE is admitted with pneumonia and confusion. As you're wrestling with the decision over a bolus of giving high-dose steroids in a person who may have an infection, you need to determine, is this a flare of lupus or simply an infection with sepsis causing confusion? They're going to ask you, which of the following will help you most at this time? Is it A, a rise in anti-Smith, B, a rise in ANA, C, a decrease in complement and a rise in anti-double-stranded DNA, D, an MRI of the brain, or E, a response to steroids? The correct answer is C. Although anti-Smith is specific for SLE, the levels do not change in an acute flare. However, complement levels will drop and anti-double-stranded DNA will rise. A rise in ANA also does not occur because these things just do not change. They're positive or negative. An MRI of the brain is not useful in lupus cerebritis. It's usually normal. And lastly, we don't treat first and see if the patient gets better. We're not House MD. To treat lupus, it's based on whether it's acute or chronic. An acute lupus flare is treated with high-dose boluses of steroids. Hydroxychloroquine can control mildly chronic disease limited to the skin and joint manifestations. Lupus nephritis may need steroids either alone or in combination with cyclophosphamide or mycophenolate. Remember, cyclophosphamide can cause hemorrhagic cystitis, so you're going to need to give Mesna. The only way to determine the severity of lupus nephritis is, unfortunately, with a kidney biopsy. And lastly, remember, belantamab decreases symptoms overall. With regards to treatment, a urinalysis is insufficient to determine the severity of lupus nephritis. The biopsy is really the only way to diagnose simple glomerulosclerosis or scarring of the kidney, which will not respond to therapy. A little tip: young patients most commonly die of an infection. In older patients, an accelerated atherosclerosis makes a myocardial infarction the most common cause of death. We're now going to move to antiphospholipid syndrome. Antiphospholipid syndrome is best treated as a separate topic because the majority of cases are not associated with SLE. Antiphospholipid syndrome is an idiopathic disorder with IgG or IgM antibodies made against negatively charged phospholipids. You can see that there are two main types. The first is that which is associated with a lupus anticoagulant, and the next are those who have anticardiolipin antibodies. Antiphospholipid syndrome presents with thromboses of both the arteries and the veins, as well as recurrent spontaneous abortions. This is one of the USMLE's favorite vignettes. Unlike other causes of thrombophilia, antiphospholipid syndrome is associated with an elevated PTT, a normal PT, and INR. So remember, antiphospholipid syndrome is in a patient who's clotting, has an elevated PTT, but a normal PT. Other tests for lupus? Well, patients sometimes will have a false positive VDRL or RPR with a normal FTA. This occurs because the antibody actually reacts with the reagent in the lab, which is actually a cardiolipin. Anticardiolipin antibodies more often give spontaneous abortions, and the lupus anticoagulant is most often associated with the elevated PTT. The best initial test is a mixing study, in which the patient's plasma is mixed with an equal amount of normal plasma, and the resulting PT and PTT is then measured. Now I want to go over the mixing study. In a mixing study, as I mentioned, you mix normal plasma with the patient's plasma. You're expecting the PT and PTT to correct. If the elevation in PTT is from a clotting factor deficiency, then the PTT will come to normal upon the mixing study. With antiphospholipid syndrome, the antibody is present in the plasma. Therefore, even normal plasma will become inhibited, and therefore the PTT will remain elevated. The most specific test for lupus anticoagulant is the Russell-Viper venom test. The Russell-Viper venom test is prolonged with antiphospholipid antibodies and does not correct on mixing studies with normal plasma. An asymptomatic patient with an antiphospholipid antibody doesn't need to be treated. However, if they've had any form of thrombosis, this includes a DVT or PE, they are to be treated with heparin and warfarin as you would any other form of thrombosis with an INR goal of 2 to 3. What does come up is the duration of treatment. It's actually rather controversial. It is not clear if lifelong warfarin instead of the usual 6 months of treatment is indicated after a single thrombotic episode in the setting of antiphospholipid syndrome. What we do know, however, is if they've had recurrent thrombotic episodes, they are to be on warfarin lifelong. Now, something you need to know. We just talked about a controversial issue, 6 months, lifelong, warfarin. The thing here is, the USMLE will avoid areas of controversy. They're only going to ask you things that are clear. They're not going to be completely outright in trying to trick you. One thing you must know is that warfarin or steroids are always the wrong answer for preventing spontaneous abortion. Steroids are simply just not effective. Also, warfarin is contraindicated in pregnancy secondary to teratogenicity.